In 2025, opioid use runs rampant across the United States, and for good reason. People are in pain, and opioids treat that pain, but there's a problem. In 2015, 52,000 Americans overdosed from prescription and illicit drug use. In just 7 years, that number rose to 108,000. Of that total, 74,000 were an overdose on synthetic opioids. Opioids have a well-studied mechanism of providing pain relief. Activating mu-opioid receptors in the midbrain inhibits the downstream perception of pain in higher brain areas. So, a pain signal travels from the source of injury up the spinal cord where it's stopped in the midbrain, preventing pain from ever being felt. Opioids are widely known for their effectiveness in treating pain, but they're also known for being addictive and deadly. Along with activating mu-opioid receptors in the midbrain, they also activate opioid receptors in our reward pathway, making them highly addictive. The question then becomes, how do we treat pain, severe pain, without opioids? Investigators heard tale of a Pakistani boy that seemingly had no perception of pain. This boy worked as a child performer that used his lack of pain perception to put on street shows. He would walk on hot coals, stab his arms, and eventually died at 14 from jumping off a roof to prove to his friends that he didn't feel any pain. Arriving in Pakistan, they found a clan of 3 consanguineous families that had no perception of pain. Not even one had any memory of having experienced pain. Many of them reported experiences where they would walk with a limp unconsciously, only to find out it had been broken for months. When the families were physically examined, they found injury to the lips and distal third of the tongue from biting themselves as children. Neurological examination revealed normal perception of touch, temperature, tickling, pressure, and normal reflexes. Medically, they were healthy in every regard, except for the fact that they couldn't feel pain. Pain perception starts with pain receptors down at your skin called nociceptors. When they detect that something's wrong, be that tissue damage or inflammation, nociceptors send a signal to the spinal cord. At the spinal cord, a second signal is sent up the fibers of the spinothalamic pathway to your brain and later thalamus to create the perception of pain. The point where the spinal cord meets sensory neurons is called the dorsal root ganglion. This is where we find specialized sodium channels for creating the signal sent along the spinothalamic pathway. Dorsal root ganglia for pain use sodium channels 1.7, 1.8, and 1.9 to create the signal that will travel up to your brain. Importantly, unlike other sodium channels, these 3 are found exclusively in the dorsal root ganglia for pain. When investigators analyzed the DNA of the whole clan and compared them to other Pakistani families, they discovered a mutation in the gene SCA9A. This gene codes for a sodium channel found only in those neurons that transmit pain signals up to your spinal cord. So, they still had pain receptors, but these receptors couldn't send a signal back up to the brain. In essence, the message was being sent to the spinal cord, but the spinal cord was unable to send it any further. In the figure on the right, you can see the 3 families laid out beside chromosome 2, where their mutation was. In the figure below, you can see the exact points on sodium channel 1.7 modified by their genetic differences. What these Pakistani families had is known as channelopathy-associated congenital insensitivity to pain. Opioids block pain signaling downstream in the brain, and sodium channels facilitate pain signaling upstream from the receptors to the spinal cord. So scientists asked, could we selectively block sodium channels 1.7, 1.8, or 1.9? Could we mimic congenital insensitivity to pain for the treatment of pain? Investigators found the experimental drug VX548 was able to selectively block voltage-gated sodium channel 1.8 to stop the pain signal from ever going up the spinal cord. In the figure below, graph A shows 2 lines. The signal sent from a neuron is called an action potential, and the black line is what an action potential should look like, with the blue line being the action potentials seen when VX548 is administered. You can tell in the graph there that the blue line is much lower than it should be, and the y-axis is the membrane voltage. Seeing that there, we can see that there's not enough, the black line is supposed to go up, and the blue line it's not going up quite like it should because the action potential isn't firing. In graph B, as we move along the y-axis, down the y-axis, the dosage of VX548 increases and the number of action potentials seen, measured on the x-axis, decreases. Looking up at the top row, you can see the baseline amount of firing. You see 61 action potentials. And then as you move down up to 10 nanomolar, you end up with no action potentials. And this is better portrayed in graph C, where in graph C we see the total percentage of action potentials decreased with the logarithmic increase in dosage of VX548. When clinical trials were run on VX548, whose drug name became suzetrigine, it was given to patients who had just had a tummy tuck or a bunion removal, as those are two commonly used surgeries for your typical post-operative pain clinical trials. Two other groups had hydrocodone with Tylenol, a commonly used opioid combination, or placebo, that is, a sugar pill. As illustrated in the graphs on the right, suzetrigine was much better than a sugar pill for pain relief, and though not depicted, was found to be just as effective as the hydrocodone and Tylenol combination. And what you see there in the graph is a scale from 0 to 10 on the y-axis of perceived pain. And then along the x-axis is time since the surgery. And what you see there is that the suzetrigine dosage on the bluer lower line with the placebo, the sugar pill, on the upper line. And the patients who had surgeries in the past reported that it provided the same amount of relief without the same nausea or constipation that they would have had from the opioids. It worked, and it worked well. In January of this year, suzetrigine was approved by the FDA as Navax for acute pain after surgery. This makes it the first drug for pain in 20 years approved by the FDA that works with a new mechanism. The journal Nature calls it a smoother way to soothe, as it was as effective in 80% of patients in clinical trials and had much less side effects than opioids. Most importantly, it's a non-addictive painkiller. Over the course of 20 years, research has taken us from investigating a peculiar family in Pakistan to a revolutionary drug in the treatment of pain, pharmacologically mimicking congenital insensitivity to pain. These are the references, including cited images, review articles, and data from the National Institute on Drug Abuse. Thank you for your time.